Good evening, everybody, and welcome to this month's CMTA webinar, genetic testing and why it is important. And I think hopefully we'll have a good evening with Tom Winder here. He's with Invitae. He's going to talk to us a bit. He's been involved with genetic diagnosis for over 15 years, and he's going to be able to really help us understand a little bit more about this process and what it can mean to us all here, for those of us with CMT. So before we get started, I just want to let you know that I'll be monitoring during the broadcast. So on the right-hand side, you have an area there for questions. And so please feel free throughout to ask any questions that you'd like. Tom is kind enough to say that he will answer questions as we go along. So we'll have time during the broadcast and a little bit of time afterward to answer any questions that you might have. And it's always a really good way to do it. So if something comes up on a slide here, please, raise your hand and we'll do our best to get to it right away. If you have any technical questions throughout, you can either use the chat window or the question window. I'll do my best to help you through any technical issues that you're having to get started. So with that, I'm going to turn the program over to Tom, and I hope you all enjoy what he has to say. Tom?
Thank you, Bob. Thanks for the invitation to present here, and look forward to it. And I'm sure we'll have some good questions. Let me get my orientation on my. I just want to mention that as a way of disclosure, I am an employee of Invitae Corporation. It's a genetic diagnostic company that performs fee-for-service commercial testing for CMT as well as many other genetic disorders. I guess also housekeeping, if my volume is okay. If not, let me know and I'll adjust things here. The agenda that I want to talk about is really it's kind of meant to be general and getting more specific as we go. So what is genetic testing and why is it important? And then also I'll do a CMT overview, which to this audience might not be that important because I'm sure you know more about it than I do, but talk about clinical perspective, history of CMT, because it is quite interesting, and genetics of CMT. It's a complex field and there's a lot known. And then we'll talk about Invitae's testing options for Charcot-Marie-Tooth, and then hopefully at the end we'll have some questions. So what is genetic testing? What do we mean by that? Just lost my cursor. Okay, sorry about that. So when we genetic testing tries to identify in an individual or in biological family members certain gene variants that can cause disease, or at least increase the risk or chance of causing disease. So you may think that technology has won this battle with Mother Nature, and genetic testing is a simple matter nowadays. However, this is really not the case at all, and we still face many challenges. And Charcot-Marie-Tooth genetic testing serves as a very good example of many of these challenges that still exist. And I'll try to highlight some of these as we go through several of these slides tonight. So of course, genetic variation does more than just cause disease. I think you probably all know that. The differences that we notice among individuals, even among close family members like siblings, result from the unique collection of genetic variation that each of us has. And there is one key exception, and that is, of course, identical twins. They have the exact genetic composition, and therefore they appear to us as being identical. Environment works on those individuals over time, and they may develop, behavioral differences and so forth. They may cut their hair different, but they are genetically identical. It's always interesting when you see identical twins. Realize the the uniqueness of that. So when we talk about genetic testing, we really only mean testing for highly heritable conditions. That is purely genetic or very nearly purely genetic. So there's a continuum that we can draw, and it shows that genes in the environment have varying amounts of influence on our outward traits, our phenotype, sometimes call it. At the far right are traits that result from environmental effects only. Our genetic makeup has little or no influence on these traits. For example, if we fail to eat enough vitamin C, we get scurvy. Okay, that's an environmental effect. Similarly, if we're infected by certain bacteria or viruses or other infectious agents, we come down with a sickness regardless of what gene variants we possess. And in the middle of this spectrum, there are traits that are more or less equally impacted by genes and environment. For example, a man may have heart disease running in his family, but if he takes really good care of himself, diet and exercise, he can potentially avoid the condition of heart disease. And at the far left of this continuum are traits that are influenced solely by our genes. For example, when a baby is born with 3 copies of chromosome 21 in every cell, he or she will have Down syndrome. Similarly, when someone inherits a disease-causing variant in the peripheral myelin protein 22 gene or the myelin protein 0 gene, he or she will have Charcot-Marie-Tooth. So something else to keep in mind is that the laboratories are only good at testing for these single gene traits or conditions. That is, diseases that are known to be caused by a single gene or by a small number of genes. The truth is, though, that most common human diseases, for example, coronary artery disease, high blood pressure, obesity, diabetes, things like this, are influenced by many genes plus by the environment. And at this time, the diagnostic field simply is not good at unraveling all these multi-gene interactions. Okay, now that we have some idea of what we mean by genetic testing, let's ask the question, why is it important? So first, genetic testing can confirm a clinical diagnosis beyond any doubt. Okay. Second, once a genetic diagnosis is made, other similar conditions can be ruled out. Right. Then genetic testing can lead to early diagnosis, possibly even before all the clinical signs declare themselves. And this obviously would enable very early interventions, and that's very important today because in many disorders, if you think about cystic fibrosis, for example, early aggressive treatment results in longer lives. And then also genetic diagnosis will often allow a clinician to better predict patients' prognosis and progression. Genetic diagnosis can help a couple make decisions about future family plans and about screening and other family members. So that can be very important. Next, a genetic diagnosis is often required for enrollment into clinical trials or research programs. And in some diseases, therapeutic drugs are even designed to treat only certain specific mutations within a gene. For example, in dystrophin that causes Duchenne muscular dystrophy. And next, a genetic diagnosis can end or prevent a diagnostic odyssey. These long years and years and years of families taking their children to various experts and specialists gets very, very expensive and drawn out, and lots of a lot of hope is expended in this process. So if a test is available, it can lead to earlier diagnosis. And finally, genetic diagnosis may help direct treatments. And similarly, it can discontinue ineffective treatments and focus on ones that are expected to actually be effective. So a common question is, can my family history tell me the same thing as a genetic test? The answer is not easy, but in general, family history is very important part of the diagnostic process used by clinicians, particularly neurologists, neurogeneticists, and genetic counselors. The family history helps choose the right genetic test options. It can rule out certain types of inheritance patterns and so forth. And I've even heard genetic counselors say the best genetic test is a good family history, and so a good family history can go a long ways. And later on tonight, I'll point you to a family tree tool, an online tool that you can actually use if you're interested in putting together your family history. So the next section, I'm going to talk a little bit about the clinical perspectives of CMT. In terms of how common or how rare Charcot-Marie-Tooth disease is, it's actually, in terms of a genetic disease, it's quite common. Statistics vary, but somewhere around 1 in every 25 people is affected. And if you compare this to another well-known genetic disease, cystic fibrosis, where about 1 in 3,500 births in the U.S. are affected. So it really is a common genetic disorder. However, in terms of all medical conditions, CMT is rare. So a common medical condition is something like coronary artery disease, and in the order of 8% of men in the population will have something like that over time. So in terms of disease burden, it's rare, but in terms of a genetic inherited condition, it's quite common. CMT is also referred to as hereditary motor and sensory neuropathy. I'm sure you've all heard that. Clinically, the main features are weakness and wasting of the distal limbs, pes cavus or high arched feet, absent or reduced tendon reflexes. Other symptoms are neuropathic pain, skeletal deformities, respiratory problems.
Hey Tom, let me ask you a question here.
Mm-hmm.
We have a question
Yeah.
there. So kind of relates to what you're talking about now with some of the symptoms or some of the effects of CMT, and also with what you mentioned earlier about identical twins. I'm just curious if you have identical twins, one, does it mean that if one has CMT, the other will have CMT? And two, would the severity of the CMT be the same amongst identical twins?
Yeah. So with identical twins, you certainly expect, well, both will have CMT. If one has it, the other will have it. And for something like CMT, which is considered purely genetic condition, there's not a lot of environmental effect, then even with an identical twin, the clinical course would be expected to be very, very similar. There could be slight differences, and those would be expected to be from things like nutrition and things that would vary between the two kids. That's a good question.
Yeah, thank you.
But it's, yeah. So in this slide, just wanted to point out that I'm sure you've all been through this. The nerve conduction velocity test is routinely used to differentiate between these two major types of CMT, axonal versus demyelinating, and I'll talk more about those later. CMT can affect both adults and children. It's an inherited condition, as we've been talking about, and treatments include physical and occupational therapy, braces, surgical corrections, and use of meds to control the neuropathic pain. One thing to think about is what else looks like Charcot-Marie-Tooth. This is the kind of thing that a neurologist would consider seeing a patient. So the differential diagnosis. By far the most common condition that causes peripheral neuropathy is diabetic neuropathy. In one study, 4,400 patients, well, there were 4,400 patients, and half had peripheral neuropathy. Okay, so these patients were diabetics, and half of them had peripheral neuropathy. So if you consider that around 10% of the population has diabetes, that equates to a lot of people in the U.S. with peripheral neuropathy due to diabetes. So this is much more common than Charcot-Marie-Tooth disease. Another type that's not CMT is inflammatory demyelinating polyneuropathy. It's another CMT-like condition, however, it's an autoimmune disorder. And finally, long-term alcohol abuse, neurotoxic medications, and infection can cause CMT-like conditions. Now a little bit about the history. I would imagine a lot of you have read some about the history of this disorder. It's quite interesting and involves some important people through history and important events as well. It was first described clinically in 1866 in France by 3 neurologists, 2 French and 1 British gentleman named Charcot-Marie-Tooth, hence the name Charcot-Marie-Tooth disease. And Charcot is considered the father of modern neurology. If you read about him, he's a really interesting guy. For that time, he was, very futuristic thinking and looking for ways to treat patients. He trained many neurologists at the time, and he was quite big into psychoanalysis and hypnosis as well. And he taught the likes of Sigmund Freud in France. So the 3 saw patients at this teaching hospital in Paris, which I can't pronounce. But even today, this hospital is one of the largest teaching hospitals and most well-respected teaching hospitals in all of Europe. It's kind of interesting that this disorder was first described there. Now, furthermore, the history is important and interesting because it's really tied in to the whole revolution, really, in human genetics. So at the bottom of this chart, you can see 1866, when the physicians first described the disorder. But it wasn't until 1992 when the first CMT gene was identified, when the duplication of the PMP22 gene was found, and found to be a cause of CMT type 1A. And then a year later, the MPZ gene was identified as causative for CMT1B. Excuse me. So what's interesting here is the span of time between the description of the phenotype in 1866 and the first gene discovery. Okay, a lot of years went by. And then, so the blue lines going horizontally represent the number of genes discovered in this particular year. So you can see this large amount of genes being discovered in the early 2000s. And that's because the Human Genome Project was completed in 2001. And what this did was allow researchers really a better roadmap of the human genome to be able to find disease-causing genes. So then you see another spike of gene discovery occurring more like 2010 to 2013, and it's still going on. And this time in history corresponds to the advent of high throughput DNA sequencing methods, often called next generation sequencing, used to do gene discovery. So the CMT genetics, oops, there I did it. Okay. So the history of CMT is really tied to a lot of medical genetics history and landmarks. Very interesting. Now we'll go on to the genetics of CMT and really consider ways in which CMT is inherited within a family. So as I said earlier, genetic testing and genetics of CMT still poses some challenges, and one complicating factor is that 3 different forms of inheritance are possible. And in some families, it's not clear what the inheritance pattern is. Usually it's because there's only one affected individual. So the 3 types of inheritance that are possible are autosomal recessive, and that's the form on the far left. And it's sometimes called horizontal inheritance because it's not passed from an affected individual down through the pedigree. It'll appear in one generation among siblings, usually. The next type is autosomal dominant in the middle. It's sometimes called vertical transmission, and that simply means that it's going from affected individual downward through the pedigree, and several generations can be affected. And then the third type is X-linked or sex-linked. So it's vertical transmission, however, without male-to-male transmission. So it's on the X chromosome being passed from a carrier mom and then to an affected son. If it is passed to the daughter, she's generally unaffected or less affected, but she can pass it on to sons and daughters as well. Whereas in autosomal dominant inheritance, the middle, again, you can have male-to-male transmission. So these 3 types of inheritance are possible in CMT. And to further complicate matters, many different genes are known to cause CMT that follow each of these inheritance patterns. So even if a inheritance pattern is clearly seen in a family, clearly autosomal dominant, that doesn't pinpoint the exact gene. We'll get to that in a bit. So the CMT types, I'm sure you've all heard the basic types. It's very confusing, I'll admit it. It's been described as an alphanumeric soup because of all the letters and numbers. And part of the problem, I think, is that the types refer to both inheritance patterns and to the nature of the nerve damage, back to this axonal versus demyelinating. So just a bit, introduce you a little bit more about that. So if you look at the diagram of the nerve body, a peripheral nerve is like an insulated electrical wire, in which the copper wire on the inside conducts current and the plastic coating insulates the wire. So on the nerve, the axon conducts impulses, and myelin, which is really just a mixture of proteins and lipids, coats and insulates the axon. Okay, and these Schwann cells, shown in yellow, surround the axon and produce this myelin, this protein-lipid mixture, and that's the insulating component. So, like I mentioned earlier, nerve conduction velocity, this laboratory procedure, can be used in the clinic to differentiate between axonal CMT, where the axon itself is damaged, and in those cases, nerve conduction velocities are normal or just mildly slowed, or it can tell the physician if it's a demyelinating CMT, in which the myelin coating is damaged and nerve conduction velocities are very slow. And of course, because it's CMT, it's got to be complicated. There's intermediate types as well. So when we use inheritance pattern and nerve conduction velocity, our current classification scheme looks kind of like this on this slide. And the most common type of CMT is the autosomal dominant demyelinating CMT, or CMT1. Okay? And the most common genes in this type are PMP22, and that's CMT1A, and MPZ gene, which comes with the name CMT1B. So CMT1B is the type of Charcot-Marie-Tooth, and MPZ is the acronym for the gene, the myelin protein 0. Okay? So those are the most common types. CMT2 refers to axonal CMT with autosomal dominant inheritance. And these, probably the most common gene for this is mitofusin, MFN2, and the type is CMT2A2. And CMT4 refers to autosomal recessive inherited types, regardless of whether they're axonal or demyelinating. So an example is the GDAP1 gene causes CMT4A. And really this categorization isn't, my sense is it's not used as much today. And the last major type of CMT is the X-linked category, CMTX. And by far the most common type of X-linked CMT is caused by the GJB1 gene, and it's designated CMTX1. And this gene previously was referred to as connexin 32. But today it's...
I have a question here, and it relates to CMTX. There's someone who's listening this evening who has, 4 generations of CMTX in their family, as I have 5 in my family. And she's curious, does it ever skip a generation? And if it does, does it stop there? Is that where it ends, or is it possible somehow that it just skips and continues on?
Yeah, it can appear to skip a generation, and the cause of that would be a girl inherits it from, say, from her carrier mom or from an affected dad, and is subclinical, really doesn't show any signs, although she has the mutated gene in every cell, so she can pass it on. So the reason she's not affected is that in women have 2 X chromosomes, and each cell will silence one of the X chromosomes in varying ratios. So it would just be by chance that a woman who carries a GJB1 mutation had like a uneven silencing of the mutated X chromosome, and therefore her clinical condition would be very, very mild or even completely normal. So that certainly happens. It's well established in medical genetics. This concept, it's named after the person that first described it, lionization. Dr. Lyon discovered this process of differential methylation of the extra X chromosome. So yes, that could certainly happen, but it doesn't go away. So that woman who has the mutation but is unaffected can still pass it on. And it can then, passes on to a boy. The boy will be affected, passed on to a girl. The girl will be variably affected as well. Does that answer the question, I hope?
Yeah, I think that does a good job. I have one more question here. If a parent has one type of CMT, is it possible for a child to have a different type? Or does it just
no. Yeah, there can be variability in the presentation, but these types, the type is specific really to the gene. So no, that's not going to change. However, the clinical, presentation can be variable even within a family. So yeah, X-linked inheritance has some crazy things, and it can appear that generations get skipped, but really they're not.
Okay, thank you.
Yeah. Okay, so I talked about the connexin and the GJB gene. And so this, honestly, it is a complex naming system for these subtypes. It's probably one of the more confusing ones in all of medical genetics. So if you're confused by the naming system, don't feel bad at all. Just try to keep in mind the inheritance pattern, and then is it demyelinating type or is it axonal type? And I think you can speak intelligently about it. Okay, really the last section is I just want to show what Invitae has available for clinical testing, and also just give a little highlight of what our company is. Because we're a new company, kind of taking a different approach to genetic testing, trying to simplify things, ultimately, hopefully, to make genetic testing more available to more people. And I think we believe that if we can do that, then genetic information is better utilized. We share the data in public databases. It's of more use to researchers and clinicians alike. So we're really trying to do things that way. If some of you pay attention to biotech news and that sort of thing, you know that there's this thing called direct-to-consumer genetic testing. So 23andMe is an example, and we're not that. Okay, we want to make things understandable to the patients, but we still require that genetic test coming to us go through a physician, and reports go back to a physician, genetic counselor, and so forth. So we really believe that the healthcare professional is really fundamental in the whole process of understanding genetic diagnosis, ordering tests, all the way through to the returning results. There you go. The company started 4 or 5 years ago with really a focus on diagnosis of inherited cancers, and has more recently expanded into other areas. My team works in the area of neuromuscular disorders, right now primarily Charcot-Marie-Tooth diagnosis, but also hereditary spastic paraplegia, dystonia, and most common muscular dystrophy, Duchenne muscular dystrophy. We'll soon expand into other forms of dystrophies and congenital myopathies and several other areas. So our current CMT test covers 32 genes that are well established in the literature as causative for Charcot-Marie-Tooth disease. So through your readings, I'm sure you've been talking to other people, I'm sure you are aware that there are more than 32 genes reported to cause CMT. However, for at least some of these additional genes, the scientific evidence is not really convincing that they're disease-causing. And in fact, in some cases, if you read the clinical description, it doesn't sound like the patients really have CMT. They have some other sort of neuropathy, but it really doesn't fall into the category of CMT. So we think right now that there's somewhere between 32 and 40 well-established causative genes for CMT, and our assay today covers 32 of them. We do routinely update our test by adding additional genes that are these well-documented causative genes, and that will happen again probably in the spring. And our ordering options are quite flexible. So the clinician can choose this overall comprehensive CMT test that covers all 32 genes, or if the clinician is really sure that it's, let's say, X-linked, they can just order, I think there's 4 X-linked genes, order that panel. And there's particular reasons for doing that kind of thing rather than ordering the broader panels. So, let's see, jumping way ahead here. So I know there's a lot of words on this slide. I'll summarize it for you. It's not all critical, but so the scientists that do this diagnostic testing for a career are always wondering how well does their test perform. And there are many ways to look at that, but one way is just to calculate the percentage of the tests that have positive results. Some people call it the detection rate, the positive detection rate. And for CMT testing, as you can imagine, with so many different genes, so many different inheritance patterns, there's not a well-established detection rate, and there's a lot of reasons for that, but it's all due to these variables. So one study may have looked at 25 genes in their test panel. Another study may have used 15 genes. So it's really hard to compare and come up with a standard detection rate. There have been some pretty large studies done, and one of them is listed on top here, Supporta et al. In 2011. They found a detection rate of 67%, which is quite high for any genetic test, honestly. And it was a large number. There were 787 positive results. And their most common types were just as we'd expect, the CMT1A and the GJB1 X-linked type. And then there was an even larger study done in 2014 that found a positive rate of 18.5%. And there were over 3,000 positive results, so a very large number of patients tested. Thus far at Invitae, our positive rate is kind of in between 27.5%. That's much smaller numbers. It's 110 positive tests. But again, the positive rate depends on a lot of things. Depends on how well the patients are characterized. Does the doctor have a really good sense that it's CMT, or are they just taking a chance at it and they just want to rule it out? So it's a difficult thing to come up with, but those are some results that you might want to see. So we've been talking about this number of genes, 30 or 40 genes verified to cause CMT, but the important thing is only a small number of these genes account for the vast majority of cases. Okay, and studies repeatedly show that 4 genes, the PMP22, the MPZ, mitofusin, and GJB1, are involved in somewhere around 90 to 92% of all cases. And the remaining 10% of cases have mutations in one of these many rare genes, the remaining 35 genes. So in the past, when DNA sequencing was still a fairly expensive proposition, the logical approach to diagnose a patient would be to test them just for those 4 genes. And particularly if there was a sign of X-linked inheritance, you could test just for 1 gene. Things have changed now with the less expensive testing methods, and the clinicians just want to go straight to the larger panel more often than not, and not mess just with the 4 genes. So finally, I just want to point out that a negative test for CMT does not rule out the diagnosis. It might seem counterintuitive, but a negative test in an affected individual is not a rare occurrence in genetic testing. And the reasons for this are, well, manyfold, but one is we've not yet identified all the disease-causing genes. And certainly not in CMT. There's certainly more genes to be discovered. And another reason is there's still the possibility for the presence in a particular patient of a mutation type that goes undetected by the current test methods. Okay, there could be a gene variant in an untranslated part of the gene that's not tested that somehow interferes with regulation of the gene and causes disease. So there's still limitations, and that's why I always recommend with genetic testing to be able to talk to a genetic counselor and really understand the limitations that come with this. And then, again, in Invitae, I've mentioned that we're really trying to simplify things. We want to make genetic testing more accessible to people, and we think that the whole process can be simplified. And one part of this is to make the billing transparent and straightforward. And I think individuals who pay for genetic testing out of their own pockets will appreciate that. And I think eventually the insurance companies are going to get on board and understand that this is the way to go. So we've adopted this 3 pricing method that applies to all our tests. So we hope it's going to make things easier for patients and insurance companies to know up front what the costs will be. So I know I've had some medical issues, and wow, you go to the doctor and you have no idea what things are going to cost. And I think particularly in genetic testing, when insurance doesn't pay for things very well, this is an important thing to know. And similarly, for the clinician, the ordering process is simplified. So they can order this one large panel, they can order any sub-panels, or they have the flexibility to make custom tests for any particular patient's need. So they can go across panels and choose individual genes that they might think are important for the patient. And lastly, just wanted to point out the family history tool that's freely available on our website. And there's the link right there. You might jot that down if you think you want to use it, because I found it's not that easy to find on our website. Let's go through a few clicks. But anyway, this is intended for anybody to use. You can construct your own family tree, putting in medical information. It's free of charge. It's not going to direct you to order a test or anything like that. And it allows you to save the information, go back to it, add to it, and so forth. So this is the same family history tool that clinicians, particularly genetic counselors, use when they're taking family history from their patients, and goes into their electronic medical records and used in the future. So if anybody has an interest, feel free to give that a shot. And with that, I think we have time for some questions.
And quite a few questions we had. So thank you very much, Tom. That was an excellent presentation. And I'll just jump right in here with the first one. And we have someone who is the mother of 3 girls and has CMT. 2 of her daughters are showing signs of CMT, but the insurance company has turned her down for genetic testing. So they're trying to figure out, is there a way to get, are there certain things you can do to get genetic testing approved? And or how much would it cost? I think you've covered that part on the out-of-pocket.
Yeah, we offer that out-of-pocket rate for patients. The other thing to remember is that the MDA, the Muscular Dystrophy Association, they don't just take care of people with muscular dystrophy. CMT is one of their disorders, as is ALS and some other things. And depending on which MDA clinic you get into, they have certain amounts of funds, and it's not huge, but some funds to do some diagnostic testing. I'm not saying it's a guaranteed thing, but I just think MDA clinics are great, and they're experts that staff the clinics. They are involved a lot in diagnostics, so it might be something to think about there if you're near an MDA clinic.
All right. So the next question is interesting. If you suspect CMT in the family, is it reasonable to have just one family member get tested and make that leap of faith to everyone else?
Yeah, that's generally what a genetic counselor would consider, and take. Well, I mean, it's real world experience. They'll have tested whoever has the best insurance, and then once the diagnosis is made, okay, they're going to know the gene and the particular mutation, and then it's a much less expensive proposition to target just that site in other individuals. It's a matter of a few $100s. So that can be done, after the first individual is diagnosed. With that information, then have other family members tested.
Okay. So had someone here who has a father who had CMT and passed away, and doesn't know what type of CMT he had, but was wondering if it's smart to get tested for it, or is it better just to wait for, I guess, some clinical symptoms to approach?
Yeah, that's a tough one. So the father was not tested, is that what I heard?
That's correct, yeah. And he passed away in 1995, so it's been a while.
Yeah, so that's a really tough one. I mean, you could do the testing, but a negative result really doesn't tell you anything, because you don't know if it would have been diagnosed in the father. One thing I think a genetic counselor would say is, try to find out when the father was becoming symptomatic, and maybe, look in the patient. Are they showing signs around that time? That's a tough one. I mean, I would recommend talking to a genetic counselor about that, someone with some experience. I just want to point out that I'm a little bit uncomfortable answering questions very, very clinical. I'm a laboratory scientist, so I don't want to take anybody down the wrong road. I really have a lot of respect for the clinicians, the genetic counselors, and neurogeneticists. So they're the experts, not me.
So that brings us to another question, or maybe it's a little bit more a good fit here. Is CMT1 caused by elongation of one of the 2 strands of DNA?
Oh, Well, I think what that means is probably the duplication of PMP22. I mean, I guess technically you'd call it an elongation of the strand. It's essentially a duplication of the entire coding part of the gene. So now instead of 2 copies, one in each chromosome 17, now there's 3 copies. And so that overproduction of that protein actually results in the disruption of the myelin on the axon. So it's the classic PMP22 mutation. And on the other type of mutation that occurs there is a deletion of one of the PMP22 genes, and that results in a slightly different condition, hereditary neuropathy with pressure palsies.
So I have a question here, and this is a good one for me too, because I was tested back in 1995, I think it was. So if I was tested in 95 and this individual was tested in the early 90s also, with all the advances in genetic testing since then, looking at your chart there that you had earlier, is it smart to go ahead and get retested, or are those results still valid?
Yeah. So the only people I think should be retested would be ones who had negative or sort of equivocal tests back then. So the thinking is, say in 1990 they maybe knew about a small number of genes, 3 or 4. Now we know about 32 to 40. So if you had a negative test back then, there's a chance that your causative gene has been discovered, and a new test would uncover that. But if you had a positive result, particularly the PMP22 gene, the MPZ gene, GJB1, no, there's no need to redo that test.
Okay. So go back to there's an individual here who has a 21-year-old son who has been diagnosed with CMT that is unlike any other that this clinician has seen this past couple of years. So they really want to know what to look for. So there's a person who's diagnosed with CMT, but there's no specific kind that the clinician has given them. Is that a good candidate for a genetic testing?
Yeah, exactly. That's there's always slightly different presentations, clinical presentations occurring. It may very well be caused by one of the known genes. So that's really a good candidate for testing. And since there aren't clues in the clinical presentation, I think the counselor would probably recommend doing the larger panel. And in this day and age, what geneticists will do is test an individual like this for specific disease panel, like CMT test. And if that comes back negative, they'll do something called an exome test. So it's almost research, but not quite. And in this test, they look at all protein coding genes throughout our genome. And really, they're trying to find a new or a novel gene that's responsible for the disease. Now, it's quite a bit more expensive than a CMT panel test, but it's used very, very commonly nowadays, and it's seen as the next step past your disease-targeted panel test. So there are options.
Okay. There's a question here about prenatal testing. I don't know if Invitae has any tests for prenatal testing, or if you know anything about that.
Yeah, we don't at this time. I'm sure other laboratories are doing prenatal CMT testing. There's no reason why it wouldn't be possible. I mean, there are issues with prenatal testing. One is it's much better to know the family mutation. Okay, if you're doing prenatal testing as a diagnostic thing, in other words, trying to find the family mutation, that's risky business. So if a parent has CMT, they know the mutation, then yes, prenatal testing is not a big issue at all.
We have another question about location. So I gather you guys are national or international. What's the procedural operation if you wanted to talk to your physician about getting tested?
Oh, okay. So we do have genetic counselors. We don't actually have physicians. So the tests are ordered by your physician. A small blooded tube is sent to the laboratory in San Francisco, and then analyzed there, reported there, and then it electronically goes back to your physician for them to interpret with you. We have, like I said, we do have genetic counselors. They're mostly there to help clinicians understand results, help them choose ordering and that sort of thing.
Okay, so just about any physician then can order the test. Is that correct?
Yeah, that's correct. Personally, I believe for something like this, Charcot-Marie-Tooth, any neurogenetic disorder, it's really best to go to a neurologist. And CMT is probably common enough that a general neurologist is going to have a pretty good idea of what they're doing. If you're talking about some really rare neurogenetic conditions, then you'd probably want to go to a specialist. But at least get to a neurologist. Academic medical centers always have excellent care for this type of disorder. And the other thing that's important is not just the physician, but since you're doing a genetic test, it's always a good idea to have a genetic counseling service. And that's one thing that Invitae can help with. If you don't have access to a genetic counselor, you can come to our company, make a phone call, talk to client services, and they'll be able to find genetic counseling service in your area.
All right. Well, I think that's all the questions. It's coming up on 9 o'clock here. Tom, I'd like to thank you very much for your time this evening. I thought it was a great presentation. I know we asked and answered a lot of questions of you. So I'll give you a few moments for some closing remarks if you want.
Sure.
If not, we can just go ahead.
Yeah, I think there was one other question that I was forwarded early on. I thought I can just real quickly, basically they're asking, where can you go to find like a clearinghouse for genetic testing availability? There's something called Genetic Testing Registry. It's a, I think, NIH-funded thing, GTR.org or GTR, Genetic Test Registry, GTR. Another one is Next, GXDX. That's confusing. Next, like the word, and then GXDX.com. And that's a site that actually lists prices. So you and your physician can actually see what's available there. So I enjoyed it very much. Good questions, and I hope everybody got something out of it tonight. Thank you.
Thank you very much, and thank you everybody for staying with us this evening, and I'll be joining us again. Take care now.